All right, guys, so we're live. Welcome to my channel. The title for today is EIT Guided Lung Recruitment of Left Dorsal Region. So EIT stands for Electrical Impedance Tomography. More precisely, I'm using the Draeger Vista 500 electrical impedance tomography that is a non-invasive monitor. It's a belt 16 electrodes, non-invasive monitor that gives you a dynamic distribution of ventilation, as well as an ability to measure various uh, regional compliances. So by looking at the EIT, we can see, one area of the lung perhaps is gaining compliance while another is losing. You really have eyes inside the lung. If you're interested in any of the introductory explanations, which I'll do more videos as well, more basic beginners. Go see my previous videos. Just for a question of time's sake, I'm not going to be explaining in great detail with PowerPoints every time what exactly the Palma Vista 500 is, and I'll be referring to electrical impedance tomography as EIT, just to make things a little simpler. So what I'm probably going to be doing is I'll be posting in videos case studies, and then after we're going to do longer live streams looking at those videos, hopefully getting other healthcare professionals here that are that can come up here and we can discuss things. What I'm seeing in my practice is we use APRV on certain patients. We have an amazing result when we're using it. I use the EIT to help guide the distribution of ventilation. Everything is guided from the conventional mode to the titrations of the optimal PEEPs. And if we are unable to get what we want with conventional ventilation, with the highest PEEP or the optimal PEEP not doing the job of opening it up, we'll transition into APRV. We use APRV, and we use the TCAV method, time controlled adaptive ventilation method, that was pretty much invented by Dr. Nadir Habashi. We've been using APRV on select patients for around close to 4 years about. We have not had pneumothoraxes. There's a lot of misconceptions about APRV. It gets a bad rap, and it shouldn't. There were a lot of theoretical concerns, but small randomized controlled trials as well as larger studies show that it does quite well. The issue is that it doesn't do in the scientific literature. It doesn't do better than the high PEEP, low tidal volume. Therefore, a lot of people sometimes can shy away. It wasn't taught to me. It was like briefly explained. It's 2 levels of CPAP, and off we go to the next thing. It wasn't well explained in school. Residents don't learn it. Staff don't know it. Therefore, it's a seriously underused mode. And I think that with the time-controlled adaptive ventilation, where the T-low is adjusted and individualized based on the patient's peak expiratory flow, making it much more individualized, where that P-low setting is not set just by the clinician. It is calculated based on the very specific expiratory flow waveform of that patient, which can change as the lung condition changes, and this adjusts the P-low to an optimal position where the recruitment that's occurring on the P-high is not being lost in the P-low. Anyways, we're not talking about APRV for this specific case. Sorry, this one is a gentleman that is unfortunately quite young. Substance abuse has ruined his heart, cocaine, and he has heart failure. Kidneys are starting to have issues as well, and level of consciousness. So I had walked by his room twice, and he was on pressure support, minimal pressure support of 6, PEEP of 6, intubated just for airway, protection, taking like these like super deep breaths, and then after, he'll have periods of apnea, and then he'll resume, like somebody who's on too much fentanyl drip kind of thing. But so this is the situation I came with. What one thing that did catch my eye, I was like, why is he intubated and he's on 40% oxygen when it's supposed to like be unrelated to his lung? He's on 40%. He needs double oxygen, and his lung is not the issue. So I said, maybe something's up. So I got curious, and I put on the Palma Vista 500, the EIT belt with the 16 electrodes. It passes 50 hertz, so 50 frames per second of electrical impulses going across the chest, and it's measuring various impedance values. Air impedes the electrical signal more and less. So all of these inspiratory, expiratory, and collapsed areas and open areas, all of these can be measured by bioimpedance values and changed into a computerized image of the distribution of ventilation. So that's the belt that I put on, 16 electrodes. And then after it spins around, it gives me a picture of the distribution that we'll see shortly. And I was like, oh, look, it's not a normal distribution of ventilation pattern. There is something happening in the mid dorsal region on the left side where there's no air entry. So we have a guy that's intubated for non-pulmonary reasons that has an atelectic or something. With the Palma Vista, the EIT, you can see the distribution of ventilation. That's all it's going to show you. It's not going to show you, it's not going to tell you it's consolidated or it's collapsed or things like that. It just says if there's distribution or not. This guy, young guy, he should not have an abnormal distribution. So he was initially on a PEEP of 6. I think I had him for a shift. I just randomly put him up to a PEEP of 8. And I think we started at a PEEP of 8 that day, and we titrated up to 14 or 16, guided by the EIT. Okay, to make sure when we're getting to 14 and 16 that these PEEPs are not causing over distension and things like that. So everything's guided. Don't forget with the EIT, nothing's done blinded. I got called to another room, and when I came back, the lung had opened up. It's too bad. It would have been nice to incrementally increase the PEEP, and then after C, with our own eyes, all of a sudden, boom, it opened up. Because the minute that it opened up, you'll see a completely different pattern of distribution. Okay, so let's get into it, guys. We had him on a PC PSV because of like the apneic period. Didn't want to put him on a control mode because he was breathing spontaneously, so allow him to breathe spontaneously. There we go. So see, he's on 40%. Here I have him on a PEEP of 10, pressure support of 6. The slope is at 0 because he takes like those like heavy breaths and stuff. Sometimes we'll use variable variability. That last button that I put at 0. So that varies the pressure support. It kind of creates more of a noisy breathing pattern that may help with the strengthening of the lung that is very susceptible. Okay, so here we are. Right over here, guys. So all the blue is where the distribution of ventilation is. So the larger the tidal volume that he's taking, he's sucking in. So the right side is fine. That region 3, which is mid dorsal, is not. We're looking at a caudal to cranial view. Therefore, it's the sternum would be here of the patient. His right lung is here, the spine. Then this is the left lung. So it's not like a AP X-ray. We're looking at caudal cranial like a CT scan, and distribution here is not happening. Ideally, we would switch this to quadrants. It would be 25, 25, 25. So we see that once we press a reference, it gets locked down here, the image. And then this will be a dynamic image, and this will be the title image, always showing the last image. There you go. You see this region I'm pointing out is abnormal.
So now I'm at a PEEP of 10. I'm going to do a PEEP right up to 14 in an attempt to recruit this area. We're going to do a PEEP trial, find out the ideal PEEP setting for this gentleman. And if we still can't get this completely opened, I might try a shift of APRV to open up that area. If we can't do it with pressure, then let's use pressure over time. So we'll use like an extended T high. He's breathing spontaneous. He'll be fine with an extended T high.
I talked too fast. I was trying to put it at 1.25, see if I could get away with it.
Because he's taking insanely huge volumes with a pressure support of 6. So we'll see what happens. Okay, so let's go up to 14. No real significant changes. A little bit more here. We increased the dorsal distribution by 2%. Okay, yeah. Sorry.
Okay, so get what you can out of right now, me talking and explaining this. After we finish the video, it's only 10 minutes. We'll go to my PowerPoint presentation. I put those results from the USB onto the PowerPoint. We'll be able to slowly go through every aspect of what we're looking, so that through this video, you'll be able to also have said, oh, I learned everything I need to know about PEEP studies. What am I looking at and how to interpret it? Okay. 2 seconds. I'll let this play.
Was the PEEP of 8, 10, 12, and 14. So we see 8 and 10. There's still some 14, 18% compliance loss, so possible de-recruitment. When we go to 12 and 14, we have good recruitment. We see no white atelectasis, and we see very, very minimal over distension, or it's in orange. It's indicating with the higher, because as you go to higher PEEPs, you tend to have loss of compliance because of over distension. Lower PEEPs, you'll have a loss of compliance usually because of atelectasis. So here with the higher PEEPs, we're seeing that there's a loss of compliance just in this area. The other thing is that if we're trying to open up this area here, you might have to exert some pressure here. And as you're trying to push open that area, you might have orange here until that lung opens. Then that orange will disappear. So it's a question of, are we going to push power into that area to open? We have to know, is this atelectic areas? Is this a consolidated area? Consolidated area, probably not going to want to put too much power there. It's not going to open up. So take into consideration that. Over here, we're looking at the yellow for residual volume delay. Anytime you have any yellow within the blue, these are unstable alveoli, cyclical opening and closing. It means residual volume delay. Here we have a compliance win or a compliance loss. So we've won compliance in this region over here, but we're looking to do some good stuff here, and nothing's happening right there yet. And here we have end expiratory lung, so recruitment of FRC slightly here, but we're not getting what we want here so far. We're going to go up to 16, one more, and see if that's a change. And then we'll just do a trial of APRV to see if pressure and time with a higher T high, exerting a certain pressure but for longer periods of time, will do the trick. Also, since we're concerned literally about the left lower quadrant, we can go to the region of interest and we can put it into quadrants. So now I can concentrate on 4. And ideally, I would like 25% of the volume to be distributed in each quadrant. Right now, we have in area 4, 10%, 9%. And this was 9% at a peep of 6, and it's 9% at a peep of.
Yeah, this is kind of the main view where you're going to click and press your reference. It'll pop up. These waveforms that you see in the middle, those are impedance values, and they'll line up with the volume on your ventilator, because impedance and volume are interchangeable. And then after you have the 3 regions of interest, they could be put in layers from ventral to dorsal, or you can have your quadrants. I believe I just put it to quadrants because we're concentrating on the now it's going to be the left lower quadrant. We want to get that as close as possible to 25%.
16. So we're not recruiting, but we will set the PEEP where it is still optimal. And okay, so let some time go by, and I'll be back in a few minutes. So over here, this was not connected to the vent, my bad, but we went from 6 to 16, and really we see that the distribution of ventilation kind of increased where the aeration was. We're hardly getting anything in sector 4 with all of this increased PEEP. All right, so this would be considered,
like I often say, right, recruitment is pressure over time. So with conventional modes, we're limited with an inspiratory time. With APRV, we don't. Of course, we can perform a recruitment maneuver. And the other thing is, as well, is like, okay, well, a higher PEEP, 16, let's say, okay, we could look 16. Is there over distension with 16? No. Okay, let's leave the 16 of PEEP for, X amount of hours and see if the 16 of PEEP. So we often, if we're not getting the result that we want at the bedside, we'll often transition to APRV. Usually by the time we leave the bedside, it opens up. So just to say that, because in the video, I'm going to start talking like, well, it's not opening up. So it's 16. So maybe, I'm going to try APRV, which is what we usually do. But gladly came back, and this gentleman was opened. So all it needed was a little more time. And I'm not sure if it was on a pressure support, on a PEEP of 10. We'll find out. I think I brought it down to 10. I got called. And when I came back, the monitor was still on, and his lung had opened up.
This region, non-recruitable. We can also look to see the regions of interest over here to see if there's any significant increase. Impedance levels are very low, so nothing special happening there either. Now I'm going to start going back down.
What we usually had him on as well was the, what we usually, we were putting him on PC-PSV, like with a backup rate and stuff like that. And so, you'd come some RT, switch him to pressure support, back to PC, PSV, back and forth, stuff like that. Blood gas is always normal. Pressure support is 6. It's him that's taking these large volumes. The point of the video, when you throw your work out there, it's there for criticism. I'm not here to debate the parameters that the patient's on. No problem with the parameters, but I'm here these videos are, so that you can learn the Palma Vista by seeing a lot of results as well. And also I'll post the APRV cases because, lots of places don't use APRV. So it's something that is missing on the YouTube. Not a lot of APRV being shown, actual cases, actual computer screen, event screens. So that's why I put them out there.
From 16, we went to 14 to 12. So the PEEP study will be done incrementally and decrementally to adjust. If we stay on conventional mode, we'll have the optimal PEEP. Yep. All right. So we're down to PEEP of 10, and I came back because they called me actually. So I was in the middle of doing the PEEP study. I had to go. Upon return with the PEEP of 10, we have a beautiful open lung. There's more distribution on the right side and the ventral. I'm going to do a PEEP study right now again to see if maybe 8 is normal. But either way, we've done some good stuff here. The bottom left that had poor distribution at 9% is now increasing to 13%. So I'm gonna do that, unfreeze it. See, we're up to 14% now. So I'm gonna wait for the next one, freeze it. Okay. Yeah, so 14%. This is great. We've increased to a normal amount with 10. So I'm going to do the PEEP titration.
Just 1 second. I just lost the share tab. Again, we're using the electrical impedance tomography by the Palma Vista 500 by Draeger. If you're really unaware, just falling on this and wondering what is this, please go to older videos where I do introductory videos on exactly what the Palma Vista 500 are.
Oh, starting to open.
Okay, sorry. So this panel measures end inspiratory lung impedance. We can scroll all along the time axis. It helps, Jason, if you plug it and connect it with the communication cable to the Draeger vent. You can use the Draeger EIT with any vent, with whatever, non-vent, whatever. You can put it on anybody. It's just that if you're not connected to the Draeger, it's not going to know all of the various changes. And you can scroll all along the timeline. So what I'm doing here is the reference was right at the start. You're going to see this region of 4, is closed, very poor, the little blip over there. What we want to do is open up basically the middle section where you see all that white. You want it redistributed to region 4 because when you have a lazy region like this that's collapsed, all the other alveoli have to take that workload and they have to deal with that additional volume that's supposed to be in region 4. So you can have over distension. So because you can have over distension of the lung when it's atelectic, so it's all closed up, and then the good alveoli are the ones that are getting over distension with the additional tidal volume. Also, on expiration, alveoli that are collapsed will tug on expiration the adjacent alveoli. So you'll actually get possible volume trauma because it's dealing with way more volume because you're at 30% capacity. So you get volume trauma there. You have atelecta trauma. You have the cyclical opening and closing. And so all of these things can happen when you have low PEEP, and low tidal volume. You're thinking, yeah, great, like PEEP's not too high, pressures aren't too high, it's probably protective. No, atelectasis can cause it is. I don't have a study pop up, but in my opinion, atelectasis is way more dangerous and occurs way more often than over distension. And when you have a lung that's completely recruited, all of the adjacent alveoli help even with additional and higher pressures to splint open each other. It's when you lose one of those guys that things start to get distorted and stuff like that. So atelectasis is a real killer. This case, for example, guy intubated, non-pulmonary reasons. All of a sudden, we're walking by. Wow, we start with a PEEP of 6, right? Because he doesn't need much oxygen. Yeah, well, 2 days into it, he's on 40% now. What if we don't catch that, and now he has something even more serious here? And now this area could have been really damaged. And then this area here could have started to be affected. And we can see that because you'll look at the yellow on the PEEP studies. Those are residual volume delays. That's showing how alveoli are being affected by the stuff that's happening here.
Open up. This was once in a while you'll see interference. They were touching the patient, but.
And this is from 12:23 to 12:40. In all, I think it's about 45 minutes this occurred. But what I'm saying is already 20 minutes in,
More interference.
They did an echo. So it kind of opened up at one point.
Then this was they were doing an echo. So anyways, everything, they left the patient recalibrated.
So this is the best look. Okay, so here's your reference, right? Good. The blue shows the distribution of ventilation. Fine. Within the blue, there's always going to be white. And that is so that the clinician immediately, our eyes, capture the white and say, okay, volumes are being distributed where it's blue, but who's taking the most brunt? Who's dealing with all this tidal volume that the ventilator is delivering? And that shows that here is white. The white you can tell is more intense here, less here. So what's happening is the tidal volume that's being pushed in, actually this area is receiving the largest amount. So when you have an atelectic area here, putting this at risk, and on top of it, it's receiving the most volume. So this is not a good pattern of distribution. It's a distribution pattern that's going to lead to lung injury. But we did manage with the higher PEEP to open up region 4, and we see this over here. So what's all these colors over on the left side? Orange means a loss in distribution of ventilation compared to the reference. And this means a gain in the distribution of ventilation compared to the reference. Where's the reference? Here. What happened when we opened up? Here, we gained blue, right? We gained distribution here. And where's that intense middle section of white, those two eyeballs staring at us here? They're no longer there because what's been distributed is here and up on the top too. Everything's nicely redistributed. Yes, there's a little bit more on the right side.
Put everything back on.
A little bit more. There's more on the right than the left, but we don't have these areas, these islands where there's potential, stressors. And because we lost distribution in the middle, and that's not a bad thing. We're talking about the volume not being lost out of the lung completely, just being lost in that region and redistributed. That's expressed as orange.
And then after, we're at a peep of 10, and the peep of 10 is holding the region 4 nicely open. We have 9, we're at 12%. So
The reason I said that it's holding is that I'm looking here and I see the impedance values after 10, and look, they're straight. If I was gaining end expiratory lung volume, meaning FRC, I'd see it going upwards. If I was losing with the peep of 10, you'd see this trending downward, meaning you're going to eventually lose that again. It's like so much information you can pull from each panel.
see, it's nicely opened up.
Any questions?
And the color code is saying that compared to here, when you're comparing this to that, you notice there's less white, there's less distribution here because it's been open there. So everything smooths out. So it's saying that air in the reference that was here has been redistributed up here and down here, making a more homogeneous ventilation. Okay. And go back to the main view one last time. And we will put the optimal PEEP for this patient, I believe. At 10 or 12. He's at 12 right now. It's at 10 right now.
Put 11.
I would say 10 to 12 is acceptable. All right, and for closing this case, last but not least, final 10, 12, 14 titration, loss of compliance, and the PEEP of 10, perfect pretty much with 12, 14, minimal overextension.
So again, I let more time pass. I don't know if we can find time on there. No, I don't see it. I think it's 13, 12 up there. So I was like, okay, one last time. So now I compared 10, 12, and 14. So when you compare 10, 12, 14, it's saying, yeah, compared to 12 and 14, there's actually less compliance. So it's saying that, so white is not good. Okay. And over here, when I went to 12, it went downwards, meaning there was less loss of compliance. I know it's a weird way of saying it. It's like, why don't you say gain or loss of compliance? So, but this specific one lets you know that the loss of compliance is going to lead to atelectasis. Okay. And then after orange would let you know that the loss of compliance is going to likely lead to over distension. So it's important to understand what these colors represent. Now, don't forget, this is the dangerous area over here. And we can see that there's some yellow residual volume delay. There's more with the PEEP of 10 at 22. And then after you have 14, then 18. So the final one that we set it at is 12. And then you can do customized analysis. It'll show you a gain in compliance in blue and a loss in compliance in orange. That's another way of looking. So what you would see here is bad compliance, and the minute you go to 12, 14, you'd see like a blue vector go up, showing that here, when you went to there, there's a gain in compliance, and etc. So let's continue.
So since I'm seeing white, and he did previously close here, and there's less cyclical opening and closing as well, 22, 14. So optimal PEEP is, in my opinion, we're going to do 12.
Okay.
Okay, so we have
all right. Just going to go to.
So the gentleman's always been taking very, very.
All right, so shameless plugging. So my channel's name, I put it as Palma Vista 500 guided APRV. If you wish to look at some of my archived videos by watching these, if you're just learning the Palma Vista, you get the benefit of the experience of all of these case studies. You'll learn from them. Very cool ones. All right. No playlist. I haven't put anything into playlist yet. But I have 47 videos out there and more to come. Okay. All right. So that's pretty much it. I am live, and the only comments that I see are from my YouTube. I cannot see comments from Facebook at the moment, I believe. Anyways, all right. Thanks a lot, and see you soon. Bye-bye.